everyone, we're going to get started now. Today we have Dr. Brown, Dr. Williams, and Matt Anderson here. This briefing is on record for 1 hour, and they'll go through the presentation, and then we'll go over to the phone lines. One question, one follow-up. I'll turn it over to Dr. Brown to get started.
Great. Thank you. So today we're going to be presenting projections and modeling data and discussing the trajectory of the COVID-19 pandemic in Ontario right now. The modeling data that we'll be presenting has been developed by researchers across Ontario universities that are part of the modeling consensus table, and this is led by the COVID-19 command table. I'm particularly grateful to Dr. Adalsteinn and her team, who's prepared a lot of the data for today's briefing. It's important to lay out what we anticipate the likely trajectory of the disease to be. It's important to do this because these models feed back on themselves. And as we know how the disease is progressing, we're actually able to shift that trajectory of the disease, particularly through adherence to public health measures. But, as slide 2 sort of shows or says, how this outbreak continues to unfold is really in our hands. We can change the outcomes and thankfully actually change the trajectory of the disease as well by adhering to public health measures. If you go to slide 3 gives you an idea about how the pandemic is playing out in different countries. And it's important to try to understand how it plays out in different countries because this gives us a firm foundation for understanding how the disease is likely to play out here. This is still a new disease. It's one that we're still working to understand fully. But as you see how it plays out in different jurisdictions, and I'll talk about the chart in a second, you get a sense of how it's likely to play out in Ontario as well. So looking here, you can see the line in Australia, the line for Canada, the line for Michigan, the line for Ontario, all of them following roughly the same shape of a very steep initial surge, and that's the first wave of the pandemic in these jurisdictions, followed by a decline as the disease comes under control, followed by this second wave or this second surge as that slope of the line starts to increase again. And to give you a sense of this, the lines themselves look a little bit different. Each country is a little bit different. The spread of the disease is different within each jurisdiction. But the overall shape of the wave, the first and the second waves, are similar across all these jurisdictions. What I also want to call attention to here is that Australia saw a significant surge, particularly in one of its states. And at the same time, they were working very hard to control flu as well. So it's important to know that we need to control COVID-19 because of its impact on our health system. We also need to be controlling the flu and addressing the flu to maintain that safety and security in our health system. If you go to slide 4, you can see more detailed information on the cases by day in Ontario. And again, this sort of crest, this first wave early on in the pandemic, followed by the decline that we saw as we got into summer, and now this sharp increase in cases again, with cases in the hundreds again new per day. Also important to note here is that there are lowered limits on private gatherings on September 19th, tightened public measures on September 25th. When these measures are implemented, they impact the rates later on. And so they control spread now, but we only see the case data later on because of the period for the disease to incubate and to transmit. And so anything you do now pays off in the future. You shouldn't expect it to change immediately, though, after you've implemented a public health measure. Going on to slide 5, I'll turn it over to Dr. Williams.
Yeah, so thank you, Dr. Brown. And I think the point I want to start off with what you mentioned, that we did bring in some measures, and they are always delayed by a week to 10 days. And some of these numbers we're seeing climbing now reflect back to what was happening back 9-10 days ago, especially the weekend of the 17th going to the 21st. And we're seeing that, and we noticed at that time there was increased casualness around the social public health measure we'd put in place, especially around gathering in younger groups. And so we made steps to make recommendations to deal with that. As a result, we brought in some further tightening of public health measures, including the messaging that what you were doing, what we did was successful in stage the first wave. We need to do again, do it well, do it consistently. And so we had to roll back some of the social gathering type aspects because our health units identified these are areas of concern and issue. And the data that Dr. Brown has shown with the modeling is that by moving on these, can we impact the curve? And we're going to talk about that in a moment. So we moved back the indoor to 10. same as the so-called social circle, which I'll talk about in a moment. And the outdoor was moved back from the 100 to the 25. That was a province-wide impact because even though the numbers were not up province-wide, the risk-taking behavior was up province-wide. And so we have to not only stop the ones that are experiencing, prevent those from having that take effect. We also, that was on the 19th, we still want to see what is the impact of that. As Dr. Brown said, it'll take sometime later this week, we might start to see its impact. Also, the tightening of public measures, also on the 25th, we were requiring business organizations to do more aggressive screening, masking, those measures of people staying home if they're ill. We had understood some are saying, well, come to work even if you are ill, or come to work even if you're in a quarantine period. Totally wrong answer. And so people have to go back to being consistent, being strident on those measures, and to do what they need to do. And then we put more targeted issues around nightclubs, certain establishments and bars, where we reduce the time, closing at 12, last drinks at 11 o'clock, and also some other going back to takeout, more as a primary role, making sure you're working with your employees, that they are doing what they need to do, both in the facility and in the back rooms and in their social hours afterwards. Closing all strip clubs. And so we did those steps. We're looking at even further ones. What will we do? And we may have more announcements as we're informed by the data and also advised by the modeling data that Dr. Brown talked about. And we will have some more actions coming from our public health measures team. The key message is, as Dr. Brown was alluding to, if you look at what happened in the first wave, we were able to flatten the curve and bring it down. Modeling said if we didn't, we would suffer consequences, and we're going to hear about those in a moment. We have to do that again. I'll talk about that at the end, but I'm going to hand things back over to Dr. Brown for some more modeling advice and direction on how we could work on this.
Thank you. So if you look at slide 6, you'll see a table here that talks about the impact of the pandemic on different age groups. What you'll see here is two pieces of information that I think are important to draw out. The first is that the impact in terms of cases spans across all groups. And although the fatality or the mortality from the disease is lower in younger age groups, young people are able to transmit the disease. And so it's important that we're looking at controlling the disease in all age groups in order to control the overall number of cases. We now know, although early on it looked to be otherwise, we now know that young people are capable of transmitting the disease. And so although death rates, thankfully, may be low among younger people, they are still able to transmit the disease across all age groups. And you can see here, as you get into higher age groups, there is a very profound impact on health as we go along. Moving to slide 7, this is a chart that shows you the growth in cases or the trajectory of cases by age group. What you'll see is that the age that has the highest rate of cases right now, the highest number of cases right now, are younger people. But what we're seeing is two important trends here. The first is that it is rising in all age groups. And this is where it becomes particularly troublesome or threatening for our health system as it rises in these older age groups. And second, what you can't see here, though, is a general increase in the percent positivity on cases, the number of people who are tested who actually show up as having the disease. And this is generally rising over time as well. What this means is that although we see a large amount of infection among younger people right now, this is likely starting to spill over into older age groups, which is where we see the most tragic and most challenging consequences for health and for the healthcare system. And if you look at slide 8, I want to talk here for a second about the likely trajectory at current growth rates. So as we talked about when we did the first modeling presentation a number of months ago, we are starting to see that sharp upward curve. And if you look on slide 8 here, we've set all of the different jurisdictions that we're looking at. We've set those curves to sort of match up when 300 cases were reported in this current surge. And you can see that Ontario, which is that thick line there, starting to grow, that thick solid line. And if things grow as we're anticipating, we will see a dramatic increase in the number of cases, with cases now doubling every 10 to 12 days, and likely over 1,000 cases within the first half of October a day, which is a remarkably high surge, unless public health measures and adherence to public health measures start to tamp down that transmission of the disease as it moves along. Just note as well that anything that we do now to reinforce the point to control the transmission of the disease will start to have an effect days later. And so there is no sort of ability to turn a switch or dial up and down on what's going on. Hopefully the next time that we do these projections, those will be successful. There'll be strong adherence to those public health measures, and we'll see a very different curve, a much lower curve than we saw right now in the modeling data. With that, I'll turn over to Mr. Anderson to talk about ICUs.
Great. Thank you, Dr. Brown and Dr. Williams, and good morning, everyone. Before I start, I did just want to recognize that today is Every Child Matters Day. Came to my attention this morning that I have neither an orange dress shirt nor an orange tie, but it is a day that needs to be recognized, and just wanted to do that. In terms of our ICU capacity, on the chart that you have in front of you, slide 9, I believe it is, just to pick up and link back to what Dr. Brown has described. If you just look at the chart on the right-hand side, you'll see a few things. You'll see a couple of dotted lines there we'll talk about at the 150 and the 350 mark. You'll also see some curves called low scenario, medium scenario, and high scenario, and those work back to what Dr. Brown has just described. The main take-home message from this, and this is about ICU capacity, is that if we stay below that first line of 150, then our hospitals, and in particular our ICUs, can operate fairly close to normal. As we go above that, if we move to the grouping between 150 and 350, things become very strained in the system as we're able to try to maintain ICU capacity. When we get above 350, we will have to make changes in order to accommodate that kind of activity in our ICUs. Now, these numbers may seem very different for those of you who might recall back in the spring when we saw this. Instead of 150 and 350, we were talking about 2,000 and 3,000. The main difference here is that in this scenario, we are trying to maintain our healthcare system and, in fact, bring up our volume on procedures. Much has been discussed about the impact of closing procedures that we did back in the spring. We are trying to not do that and, in fact, increase procedures over this period of time. That's what those two dotted lines mean, is to reflect our ability to maintain those procedures. Really what we're trying to reflect, and going back to the comments that have been made by Dr. Brown and Dr. Williams, is the profound impact that this disease can have on other aspects of our life and of our society. And what we want to do is try to protect those cases and those procedures. If you turn to the next page, please. This is just to outline. We use the ICU numbers not as a sole focus, but it's one of our great bellwethers in terms of what's happening in the healthcare system. It's also something that we can measure quite crisply and understand how the impact of the disease is on a core part of our health system. Listed here, I won't go through every bullet point, are just a sampling of the other substantial impacts that we're seeing through this disease and what is happening in our healthcare system in other areas. You've already heard Dr. Brown talk about impacts for older populations and our vulnerable populations. We are also seeing an increase in mental health and mental illness concerns and in addictions. So there are other impacts that occur when we have this disease to our society, and we try to manage those and understand the impact that this is going to have. With that, I'm going to turn it back to Dr. Williams.
Yes, thank you, Mr. Anderson. And to sum up here, and it's important, if you look at the last slide, you've heard this many times, and the aspects we want to emphasize and emphasize again, the aspect of masking when you're out in public places and you cannot maintain that social distancing. Washing your hands and the hand hygiene aspects. The distancing, those 2 meters if you're out when people you don't know and you're not in your social circle. And also if you're ill, stay home. If you need to, consult and then get tested in a timely and effective way and follow the advice of public health officials when you're doing that. People say, well, we've heard this again and again and again. Does it really work? We saw in the first wave, it did work, and it brought it down. This is what Ontarians did, and did well, and did it consistently. That which gives me great confidence to say, let's do it again. It's like a rally for the second half of whatever sports game you want to play. We've got to pull up our socks. We've got to do what we need to do, what we're trained to do, and do it again and do it well. And we can impact the curve. And we need to do it now. We've got to move on it aggressively. Some areas even more than others. So those are my comments. And so with that, I'm going to hand things back to either Dr. Brown or to Alex for questions from the media.
Please, over to you, Alex.
Over to the phone lines. Just a reminder, one question, one follow-up. We'll go over to the first question, please.
Your first question comes from Brian Lilly with the Toronto Sun. Please go ahead.
Hello, doctors, and Mr. Anderson. I'd like to hear from you about that 150-350 measure that you're using on ICUs. You say that we can maintain without any major interruption regular hospital surgical procedures below 150. Over 350, it becomes impossible. Our peak, right now we're at about 30. Our peak was 261 ICU admissions on April 12th, which was about 3.5 weeks after the state of emergency was declared. There's no discussion of additional public health measures in this document. Are you recommending additional public health measures, be it a rollback to stage 2, a lockdown, anything to that effect, in order to keep those ICU numbers down?
Okay. Even those ICU numbers, I'll answer there. I think that's why we had made recommendations to bring in actions on the 19th and 25th. And as Dr. Brown already alluded to, the impact of those, the effect of those, we won't see until a few more days from now. And one later than the other because it was implemented later. We've also continued to message on the measures I just talked about. Those are in place, should be in place, and will be in place as we recommend all the time. We are continually reviewing and making more recommendations to deal with that concern that Dr. Brown alluded to. Is it starting to spill over into our vulnerable populations, and how do we handle that? How we ramp up even more what we learned from the first wave around our long-term care facilities, our congregate settings, and other high-risk groups than that. We learned some lessons there. We're building on that, and I think we need to address that. So it's not that we're not doing anything. We're continually working at that, and we'll have some more updates as the time goes on, as we use our data to go at, I would say, surgically addressing areas of concern, because there's differences between the first wave and this one we're seeing now that we have to address and be cognizant of.
Follow-up?
Before I ask a follow-up, does anybody else wish to comment?
The only other comment I guess I could add is that on the ICUs, just to understand what happens when we get above the 350, what we end up needing to do is not only look at what our surgical volumes are, but also look at how do we move health human resources around. Again, in that first wave when we had shut down, it created some capacity for us on health human resources. So it may not be a direct impact only on surgeries. It could be other procedures as well that can be impacted as we try to make sure we've got the resources to support our ICUs.
Follow-up?
On slide 10, you mention a number of other factors beyond ICU. You talk about mental health. You talk about scheduled surgeries, home care, mental health, deaths related to opioid use increased during phase 1. So I'm wondering, how do you, as individual medical professionals, balance this with your advice to government as you hear the Ontario Hospital Association say, take the major centers back to stage 2. You've got this other letter from 20 different doctors saying, no, use localized approaches. We don't need to go that far. We've got a lot of people wondering what's going to happen next. So how do you balance the opioid deaths, the mental health, with keeping that ICU level low as you recommend various public health measures?
Maybe, would you like me to start, David, and then
Sure.
you? So, well, I'll have David comment on the public health measures. This is a great question in terms of what we can do within our healthcare system. First is that when we look at ICU and COVID, these are emergency rooms. So these are emergency visits. We don't get to choose, are we going to support these folks or not? They're coming into our emergency rooms and they need our support. When we look at the other sectors, we are trying this time around, as David has mentioned and I mentioned in my slides, we are trying to keep the rest of the healthcare system up and functional as possible. If we are able to control community spread, if we are able to get those numbers down, then we don't have to go down that path of choices. And with this disease in particular, and what we saw in previous, in wave one, sometimes we don't get a choice. If they're coming into our emergency room, they must be treated and supported, and then we start looking at where are the other places that we can move to. I would also add that in this round, we're working much more closely with primary care and home care to try to ensure that we keep those services up as much as possible throughout this. Again, if community spread can be managed, then much easier for our primary care colleagues to stay open and functional.
And I think that's an excellent question, and thank you for raising that, because we see this dichotomy of some groups want to go in one direction, and you have the other group saying, yes, but there are consequences, and you have to handle that. And we are trying to balance that out through our public health measures table, because besides COVID, we have other people that are dealing with issues, be they surgical issues or medical issues, mental health issues. And some of the COVID steps, if you come down too drastically, you exacerbate those beyond what they have already. So we're very aware of that. That's why we have continued to open the schools. We've heard from the data and the experts saying this has impact on development and anxiety disorders in children. They need that environment to go back to. And the parents and their involvement in that work there. We know those who are in isolation. Therefore, we're trying to back down on our measures with gatherings and numbers, but there are some singles and individuals who benefit from getting together to have deal with those aspects of isolation. That is not just a nice thing to do, it's a necessity for their mental health and well-being. We've heard concerns from our people working with the opioid crisis. I know Dr. Heyer has spoken to that. And those individuals, again, we see the ones that are dying, the ones that are injecting alone. They're not going to our centers. They need to go to our CTS centers and other ones. They need to be encouraged. They need to be with others around them if they're going to need some assistance at time with naloxone or Narcan to give them some help. It's the ones that do it in isolation alone that end up, unfortunately, and we're seeing those numbers increasing. These are individuals, not that old, that are passing away, and unfortunately are passing away in isolation. We do not want to put our measures in that increases that. So it's a fine balance between enough constraint on social gatherings, but allowing those other things that we have seen, whether there's some businesses and organizations, because people are suffering economically, and some are not even paying the rent, and some need to do those aspects there. So these are complex issues that the province is wrestling with, that we're working in concert with the Minister of Health with, through the Cabinet, to make sure we're balancing that, to allow Ontarians to equip what they need to do and to keep at the key task issues here without harming that or minimalizing their ability to respond. So what you've brought forward is a very important point. There's a great balance in here, and we're going to be very surgical is the term. I'm not a surgeon in that. I have done surgery, but we're going to be very careful about where we go and how we can be selective on that so that we get the major impact that we need without consequences and downsides that you've alluded to.
Next question.
Your next question comes from Mike Crawley with CBC News. Please go ahead.
I wanted to ask a question about the various scenarios and the impact to ICU. So slide page 9. Of the 3 scenarios, given how things have played out so far, it looks like the trajectory is following the low scenario. How likely is it that it's going to continue to follow that low scenario, or do you think that how high is how much likelihood is there that things could change and we could start to see ICU occupancy start to follow along with one of the higher scenarios? I'm not sure who's able to answer that.
I'll answer this. So I think it's important to look at slide 8 and slide 9 together. So slide 8 talks about cases and the likely trajectory of cases. Slide 9 talks about where we are right now with ICU use. Remember, there's infection and then a delay before the development of symptoms, the development of symptoms and the testing and likely identification of a case, and then a delay again until the development of symptoms that are severe enough requiring hospitalization and eventually treatment in an intensive care unit. So when you look at slide 8, you get a sense of where things are likely to go, given the current trajectory of cases. If you overlaid that onto slide 9, what you'd start to see is a line that looked much more like the medium or the high scenario starting to play in. And so we are right now at low, but that's because the ICU is the last measure, other than deaths, for us to change. As we see those cases changing early, we start to get very worried that the ICU use will change in a few more days, particularly as we start to see growth of cases in all age groups, and we start to see, as Dr. Williams talked about, that spillover from younger populations to older populations in terms of cases.
Follow up?
If I could ask a follow-up then, so does that imply that there need to be additional restrictions imposed to slow the rate of growth of cases?
Precisely, and we're implementing, as we said, some on the 19th and 25th. We want to see in the next number of days is and will that have impact. We have been advised by local medical officers of health and their data where they are seeing the outbreaks and the areas of concern. We have taken that very seriously. We backed it up with the data and information we have, and then are applying steps to target those aspects in particular. So we cut back on the social gatherings. We heard a lot about backyard parties, large groups that were not adhering to the social distancing, were not masking, and we have seen the consequences with the age group that Dr. Steini alluded to, with the numbers increasing there. And so we have to go after that and work at that, educate the group and saying, you've done it before, we need you to be serious about this. We've seen some impacts of going back to university, and you've seen in London where some went back to party and they didn't do it carefully and sensibly, and now we're seeing the consequence of that. So we are taking those steps, Mike, to deal with that. And now we're looking at other ones, and we're going to be looking at other venues that are a problem. We did the bars. We cut back on the time because as people seem to be consuming longer periods of time, get less and less careful about maintaining the standards. So we have listened to that advice, and we'll continue to listen to further data and advice and make further steps as we need to bring this under control and deal with these venues and areas that are leading to outbreaks and cases, and then the community spread in the various parts of Ontario.
And maybe just to add into Dr. Williams' point, there's the measures and then there's the adherence to the measures. And so every time you see a group of people on the street standing very close together, walking into a bar without masks on, every time you see a group of people greeting each other without their masks on and standing much closer than the recommended distance, that's where this spread starts to happen. It's the measures and the adherence. And so it is very, as Dr. Williams has said, and as we note in the slides, it's really important that people understand that the trajectory is really a function of their behavior. And if the behavior changes, the trajectory of the disease will change. If it doesn't, then unfortunately we'll start to look very much like the medium or high-risk scenarios.
Next question.
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Sorry, I had trouble with my mute button there. I'm wondering if you can, Dr. Williams or anyone else, can pinpoint some of the areas that you're hearing from local medical officers of health, what the problem spots are. You've already taken aim at bars. What about gyms? What about churches? What about other places that haven't been acted upon yet? And why aren't we hearing more about these things? Because I keep getting emails from readers, for example, where are the problems? Because people don't seem to know, and that seems to be very closely held by public health departments.
Yeah, thank you, Rob. And we have heard, besides the bars, there are certain clubs, nightclubs, especially some of the strip clubs, had a number of outbreaks, so we have moved to close those. We've heard about some concerns around banquet halls, where some were supposed to be maintaining a certain number and distancing, and some have been less than stringent in handling that, and so we're looking at that, trying to understand what that means. We know this is a business industry, and we know that some places like restaurants have been very good about maintaining the care of their patrons on that, but then we find out that the staff in the back rooms and after hours are socializing without those distancing, and we have outbreaks among the staff. So you have to do it in the job, around the job, and after the job. It's all part of it. And the same as we're seeing early on with some of our school activities. People are coming already infected into the school because they weren't maintaining those protections outside that area. So we've been really ramping it up, and we're having success there. Gymnasiums have been brought to our attention. Not the one where the person works out in isolation. It tends to be the group activities, everybody in a very close space, breathing hard, working hard, yelling, who knows, that kind of camaraderie, but that comes with risk. And so we're going to have to look at what to do with that one, and can we curtail that activity itself in that. We looked at aspects around churches. We haven't seen a lot in that. We continue to monitor it. There's a lot that still would like us to loosen that up even further. It still has the limitations that are under religious rites ceremony ones that have been laid out, the 30% occupancy in that. So they can do that, but we've been surprised at how many have done great jobs of having virtual forms of worship and practice, and they've really excelled at that. So we haven't seen that so much, Rob. We've heard about some other types of activities in, I would say, restaurants and restaurant affiliated, but we're continuing to monitor to see if they can give us direction. Workplaces are a concern. We find that some of the workplaces are being less than stringent about saying that their employees should stay home if they're sick. Some are saying, come anyways, or if you're in quarantine, you're feeling good, come on to work. That's not the answer, and we're seeing this sort of less than stringent and really vigilance in handling these things, and we need them to really tighten their belts in a way and stick to the task, or you're going to have a lot more outbreaks in your workplaces, and we're seeing that. We've seen successes in some areas where we haven't seen the upsweep in the migrant farm workers, where they have maintained the quarantine with new ones coming in and are holding that tight. So we have learned some things, and those areas have seen success, and as a result, the economic downside of having to close their industries has been successful. So there are successes in this, and I need the others to watch that, emulate that, and do it again, because we know it's important for you, but more important, as Dr. Brown said, it's important for our public writ large that we stay the whole task and stay focused.
Follow up?
Yeah, just in light of all that, so how imminent is some kind of measures for these, like group fitness classes, or maybe even more spot inspections in workplaces? Because I'm also getting emails from leaders who say their bosses are just totally flouting this and getting people to come in, and they're already, if an inspector shows up, and then now the masks come off again. So how can you really do anything about that? And how soon for group fitness classes?
Right. The sound wasn't totally clear, but I agree with you. We're working at those things. Our public health measure table is reviewing those various aspects, and we're hoping for some recommendations further from them in that regard. There's others that are coming up that we're trying to make sure we give some clear recommendations around other type of public events like Thanksgiving, and how to do that in a safe way coming up. We got Halloween, how to do that in a safe way coming up. These are things good for the public in one sense, but if you don't do it carefully, they can be a source of problem and direction. And at this time, as Dr. Brown would say, it's not the time to lax and go back on that. We need to be very careful if we're going to bend this curve.
Next question.
Your next question comes from Randall Dalla with National Post. Please go ahead.
Hi, I'd just like to circle back on that OHA question that was asked earlier. They suggested quite strongly that the problem should be going back into stage 2. I'm not seeing anything in your presentation today that suggests that to me. What is your take on it based on what you see? Should we be going into stage 2 or not?
So that's back to me again. If you look at stage 2 and stage 3, a number of things that we've recommended on the 19th and 25th have been rolling back of some stage 3 things back towards stage 2. So we haven't, the main things, the difference is that we haven't closed some of the businesses. Most of the ones have been okay. We've curtailed some. It doesn't mean we won't go further. We have not closed schools. because schools so far are, in spite of having some issues, they're doing quite well thus far. And we've heard the data from our experts and from our pediatricians and our psychologists and child psychologists of how critically important this is. And so we have not rolled that back. So we will continue to look at different measures. So when we opened up the stages, we did so with opening up more and more venues. And then we had some issues because the province locked down totally back in the first wave, and it was affected the whole province wide. And I know Dr. Brown may want to comment that. There was all throughout the whole province. We're seeing now very much concentration in certain dense urban areas, and we may have to do even more further stringent actions that would move them closer back down to a stage 2. They've already moved some way down there, and we'll continue to look at that. At the same time, we're cognizant of closing down too many businesses without data to support that. As a draconian measure, we would like to have some evidence to support that these businesses who said they have been vigilant and striving to contain that, and we don't see the data to support that, so they would say, well, why are we being closed? If we're doing all we're supposed to do, we've invested a lot of money to put these protections in place. And the public, in order to get what they need on this longer run, we're now a number of months into this, they will need those services if it's done in a safe way, if it's consistent with the measures and principles. That's the key difference between now and when we locked down in March.
Follow up?
Yeah. I also wanted to ask you about positivity. There was a mention earlier of it, and it's been discussed quite a bit this week, as case numbers and testing numbers go up. You mentioned that it was going up somewhat. Could you compare positivity percentage now to in the previous peak?
So I can comment, but maybe Dr. Brown would like to comment on how that. It's a good question, and if you're trying to compare, and that's where I'll be asking Dr. Brown to comment some difference between this wave versus the first one and how we're approaching it differently. In the first wave, remember, we were trying to get, and Mr. Anderson can comment on that, how we were originally trying to get our tests even up to 10,000 a day in those early days into March and April. And that when we reached 10,000, that was a major hurdle for us. And our highest day back then in April, in third week in April, of 650, we had a positivity rate of 7.5. We did 10,000 tests, and we thought we had done a lot of testing then. That's pretty small compared to what we're doing now. And our percent, even with now this past week of numbers well over close to 40,000 every day, and great work by everybody in the team, and the labs, and OH, and everyone's doing a fantastic job. We've just coasted up, you'll see some results today, up to 1.5. Whereas some other provinces that are doing less testing are at a higher percent already, 3 to 4%. So it's unique in Ontario, doing this volume of testing with our population, and how that might impact us and give us further information to a modeling group, and maybe Dr. Brown would like to comment about that. So there are differences. We're trying to understand what those are, and what does that mean as far as any modeling directions and informing our modeling group with even more data. So maybe Dr. Brown would like to comment.
So when we're looking at things like this pandemic, we want to understand the total number of tests, the total number of cases, and the percent of those tests that are positive. And as all three trend up, those are warning signs. As you test more, you will find more cases by definition, but if the percent positivity is starting to move up again, as it is now in virtually all age groups, that tells you that the disease is starting to spread wider and faster. And so when we try to interpret this from a modeling perspective, it lets us know that we are at risk of getting towards those higher growth scenarios. What is different right now is that we have a much more extensive testing apparatus earlier on in this surge compared to where we were, as Dr. Williams said, with the last surge. So we would expect to see a lower percent positivity overall. It's the direction that we're always looking at that's the most important thing, and that's why the growing positivity is of concern.
If I may just add one additional comment to it, and just to echo a comment that was made by Dr. Williams earlier, we also have the capability now of being able to run positivity at the public health unit level or at a local level. And so again, as Dr. Williams mentioned, we are seeing quite a contrast across the province. So we still have some areas of the province where we are 0 or near 0 in positivity. And then we have other areas like Peel and Ottawa and Toronto where we're starting to see that move up up towards 3%. And picking up again on the comments here, when you're testing at the volumes that we're testing at, we look at where we were, 4 weeks ago, 5 weeks ago to here, and we are starting to see those changes, particularly in those urban areas that Dr. Williams mentioned.
Next question.
Your next question comes from Alison Martel with Reuters. Please go ahead.
Thank you. On slide 8, it looks like Ontario is on the state of Victoria's trajectory. Am I understanding that correctly?
That's right.
Follow up.
Is it?
Follow up.
Maybe she didn't hear your answer.
Oh, sorry. If you didn't hear me, that's correct. Where we're modeling right now suggests that we are starting to get closer to where Victoria was.
So Victoria took very strict measures to reduce infections around this point. So, Dr. Brown, are there any precedents for other jurisdictions to suggest that a surgical approach can achieve the same reduction in cases that Victoria achieved? What's our model here?
So in terms of the model, I can answer that, and then Dr. Williams may want to talk about the public health measures. In terms of the model, what we saw in Victoria, and if you go back to, say, the Australian chart early on, which is a helpful one here, you saw the introduction of the measures, and actually quite stringent measures, and growth during that period of time, and then a reduction. So I think in terms of the modeling, what we do see is the stricter the measures, the stronger the measures, the stronger the adherence. The faster or the sharper the decline following that. We haven't seen any jurisdiction that has seen a drop in cases without stricter measures. But it's important to note that whatever the measures are put in, there is a lag until they start to drop the cases. But no precedent for a jurisdiction that's seen a drop without extensive public health measures.
Follow up.
That was my follow-up. Thanks.
Next question.
Your next question comes from Cynthia Mulligan with City News. Please go ahead.
Hi there, everyone. Thank you for taking my call. I'm wondering, getting back to how you're trying to keep the hospitals operating and surgeries going, do you have any data on the collateral damage from the first wave when you emptied out the hospitals and most surgeries were postponed? Do we know if there have been any deaths or, cancer patients, cardiac patients?
So I'm happy to answer that, Cynthia. Thank you for the question. There's a number of studies going on through a number of different channels to look at, can we get a clear answer to that question? Time, of course, is a major factor for us, right? So understanding, there has been some studies done looking at from a theoretical model, is there a way in which we can project what kind of impacts this would have? We're also looking at, through ICES and others, doing studies around your very question. So at the moment, I would say that we have some theory around the kind of impact that we've had by the reductions. And as we've also heard from Dr. Williams, many experts will have also weighed in on, although the data is still early, there is very good reason to expect that we are going to have negative impacts, particularly, and I'll go back to the schools example, of if we were to keep those schools closed for our kids, and reference on that. I maybe would ask Dr. Brown if he wanted to add anything else from the academics and research perspective.
Yeah, so thanks, Mr. Anderson. It's pretty clear from all the types of modeling that's going on right now that if you start to restrict access to services, particularly necessary services, whether it be surgical interventions for cancer, chemotherapy, whether it even be preventive health measures like immunization or screening checks, they will have impacts. Some of those will show up pretty quickly. Some of them will show up over longer periods of time. And just to kind of reinforce the point, the longer-term consequences, like some of the mental health consequences and some of the physical health consequences related to substance use, will have a long trajectory and will be, just like the pandemic, profoundly inequitable as well in our society.
Follow up.
Thank you. I have sort of a follow-up and a half to that. Do you have any solid numbers on cancer patients, for example, from these studies so far? Do you have anything more concrete that you can give me? And my real follow-up question is, we're seeing the hospitalizations going up. We know the majority of patients have been younger, or COVID cases are younger, but are we seeing younger or older people being hospitalized right now?
So I can make a comment to your half question and then a quick comment on the latter. I don't know if Dr. Williams will want to add to that. So on your half question, I would suggest, Cynthia, you may want to connect with me afterwards, because we do, through Ontario Health, do some of the modeling and research that you've described. I don't have that information sitting here in front of me, but we can certainly get that for you. And with respect to hospitalizations, I have not seen data that suggests that it is changing the pattern. So the pattern on hospitalizations, as far as I have seen, is very similar to the hospitalization patterns that we saw in phase 1. What's different, of course, is the disease prevalence in the younger grouping. So going back to one of the comments that Dr. Brown made earlier, our concern is that if we start to see that shift, and we're starting to see it, we may be starting to see it now, where we're moving away from the younger populations who are carrying this disease into the older, we will start to get back into the same types of challenges that we had in wave 1 with hospitalizations.
Next question.
Your next question comes from Sean Jeffords with the Canadian Press. Please go ahead.
Hello, everyone. I wanted to ask about the modeling that was released earlier this year that had data on projected deaths based on the pandemic. I'm wondering if that modeling has changed at all, and where we stand on expected deaths because of the pandemic.
Sure. So when we released the initial projections of deaths and cases, that was based on a very sharp growth trajectory. Thankfully, through the imposition of public health measures, we were able to bring that trajectory down, and you saw a fraction of a quarter, a third of the expected deaths that we might have seen. We're essentially in the same place now, that we are starting to project that same type of surge with a significant death count that would follow on that. If you look at the chart that looks at the mortality ratios, if we see a growth among our mortality rates, if you see a growth in our older population in terms of the cases, you will see a growth as well in the number of deaths, and you will see the types of deaths that we were anticipating early on again. We often talk about the impact on the health system as one of the critical challenges we're facing. There is a health impact, particularly in the older population as well, that if we can bring down the case rates, if we can bring down the transmission, you'll see that death rate fall again. But probably, if we were to model those death rates and present those here today, you would see very similar potential high death rates in the province.
Follow-up?
Yes, I'm wondering, just based on the data today, I mean, it seems like this is crying out for further action, and I'm wondering what the metric is, what people, the government will use and the public health table will use to decide that further action is necessary as we proceed over the coming weeks, because it sounds as if we're taking a pause right now on further restrictions or further actions to address this issue outlined in this modeling.
So, as we said before, no, we're not taking a pause. We're continuing to assess the situation. The numbers you're seeing today were a result of about 7 to 10 days ago. We took action, even when the numbers were back then starting to go up, because we were concerned already with what we were seeing. So before they came to this concerning numbers, we implemented the stuff that we noted already on the measures on the 19th and on the 25th. And our public health measures table is making other recommendations and working on different aspects to deal with the provincial issues, the regional issues, and the matters that are addressed in the data that's coming forward. So there's no pausing going on. They're meeting on all the time. They're going last night till late and looking at these different aspects, because as was asked earlier on in the technical briefing, if you take wide swath type activities, some are very appropriate and meaningful, especially the broad measures around social public distancing. If you do things too aggressively whole province-wide, while it may be a big issue for Toronto, there's a whole large part of Ontario outside Toronto that's saying, why is this impacting us? We are keeping the numbers down, we're doing okay. So we want to make sure, and as any doctor, first do no harm, but at the same time, you don't stop. If you need to do surgery, you start ahead and you do the surgery. But you do the surgery with the right patient at the right time and the right procedure. And that's how it works, and you work on that. The difficulty, as Dr. Brown was alluding to, is that as a physician, I can say to someone who's had an event like a heart attack and saying, I want you to take these medications very stringently. I want you to do these behavioral changes. And 4 or 5 years later, the person's back in the emergency department saying, well, I took it for a bit. I just didn't feel it was necessary. I guess I don't know why I got another heart attack, and saying, what didn't you understand? And people have to take these recommendations seriously. And as Dr. Brown said, we can make them, but if you close down institutions, people just go around it. People have to stay to the task and do what they need to do the protection. Ontarians have done it. We did it the first wave. We need to do it again. So we can bring these measures in. The key is these ones we said today. Everybody has to do their part in the right thing and not do workarounds and just say, well, whatever. We don't need that whatever attitude. We need to know what else can we do, not whatever.
Next question.
Your next question comes from Ivan Semenchuk with the Globe and Mail. Please go ahead.
Thank you very much. It's Ivan Semenek. I appreciate the opportunity. I would like to ask a question about slide 7. This may be for Dr. Brown, but I'd love to hear from anyone who has thoughts on this. I would just love to have a bit more unpacking about this idea of spillover. You know, how much of that is, you know, people in that 20 to 39 group directly driving infections in other age groups, or how much of it is age groups, you know, across age groups also engaging in kind of less careful behavior, but maybe to a lesser extent? You know, does the data say anything about the dynamics of, you know, what spillover really means? And also, does it say anything about the impact of going back to school for those under 20?
Sure. So there's a lot in that question that I'll want to unpack a little bit, but there's two challenges in trying to answer your question. The first is that we don't know where all of our cases come. We talk about what we say is an epidemiological linked or an epi-linked case. If that number is a low number, if we only know, say, half of how many of our cases actually where they came from, it's hard to say this is because people mixing across age groups or people being in the same area of different age groups and the spillover happening that way. But it is clear as we start to look at it that there is this spillover starting to happen. And whether this is a young person gets infected and goes home and shares it with a parent or an older relative, whether it is younger and older age groups being in the same place and getting infected from each other. Hard for us to answer that. There's ways of doing this through genetics. There's ways of doing this through case and contact tracing that might help. We're not able to answer that question. What is clear, though, and this may also answer the second part of your question, is that we're seeing growth across all age groups. You can see it there on slide 7. And we are seeing this spillover phenomenon where an initial growth in younger age groups, you can see that very rapidly rising curve, as we actually saw it earlier on in the first wave, is now starting to pull up those other curves. And regardless of the route, they are on that upward trend, and that's where we get into particular danger to our health system and particularly high rates of mortality or high numbers of mortalities.
And I would add, I think you made a good point. While we're going after the 20 to less than 50s, certainly we have reports that there's people in their 60s and 70s and 80s who are letting the guard down. They're not 20s and 30s, not the only ones in the bars, or going out in social gatherings and not wearing protection. So while we're looking at one group and the rise in here, I think you raise a good point. Some of those ones are asking again, like we did in the first wave, those over the age of 70, especially if you have comorbidity and other health issues, you need to reduce the time you're out in public and to put on the mask. And some, you know, you get some attitude saying, well, I didn't do it, I'm not going to do it. That's at great peril. I would really strongly recommend you need to go back and be strong, because you have more to lose because your condition, your health is not as good as the younger ones. And we're seeing now more illness in some of the younger people. and we still don't know, it's a new disease, the long-term consequences of this illness in young people. We're getting some other data in, so it's not totally a benign non-issue. And the answer is we don't know yet because we don't know yet. It's still new. And so we can't be cavalier about it. So I think your question's a good one. Every age group, some members and some people are not being careful. And so we're not trying to just go after one group. I want the whole population to be careful.
If I may just add one quick comment to it as well, and it's not at the, as Dr. Brown talked about with the epi-linked case where you're doing it at an individual level. But when we look at the data at a macro level, we know we saw it in phase 1, we're seeing it to some degree as well in wave 2, that the indicator of disease moving into a congregate setting like a long-term care home, there was a harbinger before that. We see an increased activity in the community. So while we may not be able to link specifically that it was this person who carried that and brought that into the home, we do know that if we see an increase of activity in the community, it puts our congregate settings at risk. So again, going back to the comments that have been made earlier and to Dr. Williams' plea, it's down to all of us to do our part to protect at the community level. That's the best way that we can protect those who are more vulnerable.
Follow-up?
Quick follow-up. I think this is related on the next slide, slide 8. I'm just wondering why the October projection is so different from the first wave. I mean, the September numbers aren't great, but they're kind of tracking the first wave, and then you really see kind of a steep upward climb, and the projection goes way, way up. So what's going on there that's pushing it so far away from the first wave?
Yeah, sure. So actually, in some ways, this is not that different from the first wave. What you see here is a line that we've normalized to 300, starting there, but it's this change in the slope of the curve as it goes along that we start to model on here. And so that's why it starts to look like it's growing. It's not the overall direction of that whole line. It's how that line is changing over time. And it may be a little bit hard, I'm sorry, to see here on the chart, but that upward curve is what makes us very concerned. And that's why it starts to be a very, very, very rapid growth rate like we were concerned about in the first wave before the imposition of the public health measures.
Next question, and this will be the last question.
Your final question comes from Nicole Lampa with CTV News Kitchener. Please go ahead.
Hi, thank you for taking my question. Earlier on, I think I heard that you said that you were comparing our trajectory similar to what's going on in Victoria. And, looking at the numbers and looking what they've done, when they hit 679 in Victoria, their largest city, there were major restrictions, basically a curfew from 8 p.m. to 5 a.m., and classes went back online in Melbourne. I'm just wondering, looking at the chart, if we're about to hit those numbers in the next coming days, can we expect similar measures to happen in the larger hotspot areas in Ontario?
So our public health measures table are looking at the, I think you're more referring to Melbourne and what they did in those type of settings, fairly strong draconian measures, trying to look at what worked and what didn't work. And they did a number of things. So it was a collection of things, and there's some parts they knew did work and some weren't so successful. So we're trying to understand that to say, is it applicable in our setting here? Does it follow in some of our urban centers that we're having our challenge with at this time? So we're looking at that. We're emulating some activities with closing down in that. So we're going to monitor that. Even our large city, when you quoted some of the numbers, most of those were in the city of Melbourne. We don't have those numbers yet in Toronto, but we continue to watch it. And of course, Toronto is quite a bit different than Melbourne, especially in the GTA and population. So some comparisons are useful. And you have to look at the seasonality of what was going on also at that time in Australia as compared to now. So we're into, it's a bit of a juxtapose. So we're trying to be informed by that. And if there are things that we could emulate and would be useful, we'll look at those. But right now we're in the review process.
Follow-up, and this will be the last question.
I'm just wondering, in regards to your ICU projections, will they be potentially lower with the I guess, new restrictions and policies and beefing up long-term care homes.
Can you repeat the question?
I'm just wondering, with your ICU projections, how much of a factor of what you've been doing or what the province has been doing in long-term care homes will have an effect on those projections?
Sure.
So if we start to see, so it's maybe a little bit of a challenging question to ask because we're always doing projections on this. If we see the current growth of cases hitting ICUs staying at the current trajectory, we will not get into the challenges around capacity that we were worried about in the first wave and that you saw have tragic consequences in other jurisdictions like New York City or Northern Italy or Spain. What will happen is if the activities in long-term care homes reduce the growth of cases among older people who are very vulnerable, we won't hit that, there's a good chance we won't hit that bottom line or the top line that Mr. Anderson has discussed. But if they are not effective, and this is a really important but, if they're not effective, you will see a rapid growth of cases requiring ICU care and ventilation, and you will start to get to that place where necessary surgeries are being canceled or postponed, where whole facilities are challenged in terms of providing care, and that big impact across the entire healthcare system or health system, whether it be surgery or preventive care or mental health care or addictions care. All these things will have a big impact, but it's something we would have to see the change in the trajectory to be able to model effectively.
Thanks, everyone.
Thank you.